रब्बी इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली अल्लाहुम्मा इन्नी अस्अलुका इल्मन नाफ़िअन रिज़्क़न तय्यिबन व अमलन मुतक़ब्बला शिफ़ा मिन कुल्ली दा. This is Dr. Zunaira Faiz, gynecologist. Today I am going to discuss about the labor, its different stages. Hope I will discuss these lectures in part 1, part 2 or part 3 depending upon the length of the slides and lecture to make it easier for you to understand and to watch the video. Definition of the labor: series of events that take place in the genital organ in an effort to expel the viable products of conception out of the womb through the vagina into the outer world is called labor. It may occur prior to 37 completed weeks, when it is called preterm labor. Delivery is the expulsion or extraction of the viable fetus out of the womb. Normal labor. Normal labor, it is called normal if it fulfills the following criteria: spontaneous in onset and at term, with vertex presentation, without undue prolongation, natural termination with minimal aids, without having any complications affecting the health of mother and or baby. Abnormal labor, this is called dystocia. Any deviation from the definition of the normal labor is called abnormal labor. Date of onset of the labor. It is unpredictable to foretell precisely the exact date of onset of labor. Calculation from Neagle's formula is only a rough guide. Based on formula, labor starts approximately on the expected date in 4%, 1 week on either side in 50%, 2 weeks earlier and 1 week later in 80%, at 42 weeks in 10% and at 43 weeks plus in 4%. Causes of onset of labor: uterine distension, feto-placental contribution, estrogen, progesterone, prostaglandins, oxytocin, neurological factors. This is all about the hypothalamus, pituitary, then ACTH, fetal adrenal, glucocorticoid. This is the placental hormones. It is all the combination of these different factors. They are going to interplay to perform the labor. Estrogen. Increase the release of oxytocin from maternal pituitary, promotes the synthesis of receptors for oxytocin in the myometrium and decidua, accelerates lysosomal disintegration in amnion cells, resulting in increased prostaglandin synthesis, stimulates the synthesis of myometrial contractile protein actinomycin through cyclical AMP, adenosine monophosphate, increases the excitability of the myometrial cell membranes. Progesterone, it increased fetal production of the dihydroandrosterone sterone sulfate and cortisol, inhibits the conversion of fetal pregnenolone to progesterone. Progesterone levels therefore fall before labor. It is the alteration in the estrogen-progesterone ratio rather than the fall in the absolute concentration of the progesterone which is linked with the prostaglandin synthesis. Prostaglandins. They are the important factor which initiate and maintain labor. The main sites of synthesis of prostaglandins are amnion, chorion, decidual cells and myometrium. Synthesis is triggered by rise in estrogen level, glucocorticoids, mechanical stretching in the late pregnancy, increase in cytokines, infection, vaginal examination, separation or rupture of membranes. Oxytocin receptors, they are increased in the uterus with the onset of labor. Oxytocin promotes the release of prostaglandins from the decidua. Oxytocin synthesis is increased in the decidua and in placenta. Vaginal examination and amniotomy cause rise in maternal plasma oxytocin level. This is called Ferguson reflex. Neurological factor. Both alpha and beta adrenergic receptors are present in the myometrium. Estrogen causes the alpha receptors and progesterone, the beta receptors, to function predominantly. The contractile response is initiated through the alpha receptors of the post-ganglionic nerve fibers in and around the cervix and the lower part of the uterus. False labor pain. Features. Number 1, that is dull in nature and usually confined to the lower abdomen and groin. Number 2, continuous and unrelated with hardening of the uterus. Number 3, without any effect on dilatation of the cervix. Number 4, usually relieved by medications. Pre-labor, premonitory stage, begins with in primigravida 2 or 3 weeks before the onset of true labor. In multigravida, few days prior. Features of pre-labor. Lightening. You can see the lightening means that the abdomen, that is the protuberance of the abdomen, it is shifted little bit downward towards the pelvis. Cervical changes and appearance of false pains. True labor pains. Features of the true labor pain: painful uterine contractions, labor pain at the regular intervals, contraction with increasing intensity and duration, show, that is PV, that is pervaginal bleeding, progressive effacement and dilatation of the cervix, formation of the bag of waters. Stages of labor. First stage of labor, that is, and then second stage of labor, following third stage of labor, and then in the last fourth stage of labor. First stage of labor, this starts from the onset of the labor pain, true labor pain, and ends with full dilatation of the cervix. It is, in the other words, the cervical stage of labor. Its average duration is 12 hours in primigravida and 6 hours in multigravida. There are 2 phases of the first stage of labor: latent phase and active phase. Phases of the first stage of labor. The latent phase is the time between the onset of labor and 3 to 4 centimeter dilatation and cervix becomes fully effaced. It usually lasts between 3 and 8 hours, being shorter in multiparous women. The second phase is the active stage and describes the time between the end of the latent phase, 3 to 4 centimeter dilatation, and full dilatation, 10 centimeter. It is also variable in length, usually lasting between 2 and 6 hours. Again, it is shorter in multiparous women. During active phase, cervical dilatation during the active phase usually occurs at 1 centimeter per hour or more in a normal labor. Second stage of labor. It starts from the full dilatation of the cervix and ends with expulsion of the fetus from the birth canal. It has got 2 phases. Number 1, propulsive phase starts from the full dilatation up to the descent of the presenting part to the pelvic floor. Number 2, expulsive phase is distinguished by maternal bearing down efforts and ends with the delivery of the baby. Average duration is 2 hours in primigravida and 1 hour in multigravida. Third stage of labor. The third stage begins after expulsion of the fetus and ends with expulsion of placenta and membranes. It also involves the control of bleeding. A third stage lasting more than 30 minutes should be considered abnormal. Fourth stage of labor begins with the delivery of the placenta and ends 2 hours later. Physiology of the first stage of labor. Uterine action. Fundal dominance. Each uterine contraction starts in the fundus near one of the cornua and spreads across and downwards. The contractions last longest in the fundus, where it is also most intense, but the peak is reached simultaneously over the whole uterus and the contraction fades from all parts together. Polarity. Polarity is the term used to describe the neuromuscular harmony that prevails between the 2 poles of or segments of the uterus throughout labor. During each uterine contraction, these 2 poles act harmoniously. The upper pole contracts strongly and retracts to expel the fetus. The lower pole contracts slightly and dilates to allow expulsion to take place. If polarity is disorganized, then progress of labor is effective. Formation of the upper and lower uterine segments. The upper uterine segment, having been formed from the body of the fundus, is mainly concerned with contraction and retraction. It is thick and muscular. The lower uterine segment is formed of the isthmus and the cervix and is about 8 to 10 cm in length. The lower segment is prepared for distension and dilatation. The muscle content reduces from the fundus to the cervix, where it is thinner. Formation of the upper and lower uterine segments. Then, when the labor begins, the retracted longitudinal fibers in the upper segment pull on the lower segment, causing it to stretch. This is aided by the descending presenting part. The retraction ring. The ridge forms between the upper and the lower uterine segments. This is known as the retraction ring. The physiological ring gradually rises as the upper uterine segment contracts and retracts, and the lower uterine segment thins out to accommodate the descending fetus. Once the cervix is fully dilated and the fetus can leave the uterus, the retraction ring rises no further. Cervical effacement. Effacement refers to the inclusion of the cervical canal into the lower uterine segment. It takes place from above downwards, that is, the muscle fibers surrounding the internal os are drawn upwards by the retracted upper segment, and the cervix merges into the lower uterine segment. The cervical canal widens at the level of the internal os, where the condition of the external os remains unchanged. Now, cervical effacement, you can see in this picture, this is not effaced. Not effaced, it is uneffaced cervix, and that is the same length is about 2 to 3 cm and thick. Again, cervical mucus plug is present, and then here you can see as the thickening, it is the shortening of the length of the cervix, and when it becomes shortened, and we call it as effaced, it becomes thin and short. Cervical dilatation is the process of enlargement of the os uteri from a tightly closed aperture to an opening large enough to permit the passage of the fetal head. Dilatation is measured in centimeters, and full dilatation at term equates to about 10 centimeters. Now again, cervical dilatation, we can see in this picture, this is uneffaced cervix, then it is 1 centimeter, 5 centimeter, and then dilatation, it is about 10 centimeter. And dilatation, the gradual opening of the cervix measured in centimeters from 0 to 10 centimeter. 1, 2, 3 centimeter, 4 centimeter, 5, and then 6 centimeter, 7, 8, 9, and finally this is 10 centimeter. Show. As a result of the dilatation of cervix, the operculum, which forms the cervical plug during pregnancy, is lost. The woman may see a blood-stained mucoid discharge a few hours before or within a few hours after labor starts. The blood comes from the ruptured capillaries in the parietal decidua, where the chorion has become detached from the dilating cervix. Formation of the forewater. As the lower uterine segment forms and stretches, the chorion becomes detached from it, and the increased intrauterine pressure causes its loosened part of the sac of the fluid to bulge downwards into the internal os to the depth of 6 to 12 mm. The well-flexed head fits snugly into the cervix and cuts off the fluid in the front of the head from that which surrounds the body. The former is known as forewater and the latter is known hidewater. Formation of the forewater and hidewater. This you can see, it is the forewater, and this is the hidewater. Forewater is, it is before the head, the presenting part. General fluid pressure. While the membranes remains intact, the pressure of the uterine contractions is exerted on the fluid, and as the fluid is not compressible, the pressure is equalized throughout the uterus and the fetal body, it is known as general fluid pressure. You can see all around because of the fluid, there is the pressure all around because of the fluid. General fluid pressure. Rupture of the membrane. The optimal physiological time for the membranes to rupture spontaneously is at the end of the first stage of labor, after the cervix becomes fully dilated and no longer supports the bag of forewater. Fetal axial pressure. During each contraction, the uterus rises forward and the force of fundal contraction is transmitted to the upper pole of the fetus down the long axis of the fetus and applied by the presenting part to the cervix. This is known as fetal axial pressure. You can see the whole of it is transmitted to the fetus. Physiology of second stage of labor. And this now I end up in the part 1 of this labor lecture, and inshallah I will discuss the physiology of the second stage of labor in my second, that is part 2 of the labor lecture. Hope this will increase your knowledge. Jazakallahu khairan.